In Chapter 4, we're going to discuss mechanical circulatory devices, or MCDs. The different ones we're going to discuss are the intra-aortic balloon pump, or IABP, the ventricular assist device, or VAD, and extracorporeal membrane oxygenation, otherwise known as ECMO. The intra-aortic balloon pump is a machine you'll encounter in the intensive care unit. There's a balloon in the aorta that increases blood flow to the heart, and it actually relieves the workload of the heart. With this device in place, you can actually increase cardiac output by 30%. A patient may have femoral access or axillary access. With femoral access, to maintain the integrity of the line and to prevent migration, the patient should avoid hip flexion and the head of the bed should be 45 degrees or less at all times. Lots of times these patients are on strict bed rest, but some facilities are allowing these patients to mobilize with precautions in place. Axillary access does allow for more ambulation. If this device becomes disconnected or if you see any bleeding, you want to call the nurse immediately. A ventricular assist device, or VAD, is an implanted device that helps the heart pump blood when the heart is weak and unable to provide enough blood flow to perfuse the body. For instance, in patients with heart failure. This device is attached to the left ventricle with a pump, and there's a drive line that exits the body in the abdominal area. The patient will be connected either to a main console or to batteries if they're more portable. Extra training is required to mobilize these patients, and if the VAD alarms, you want to get the nurse immediately. Some clinical considerations when working with a patient with a VAD. Many times with these newer pumps, the patient will not have a heart rate. There's no palpable pulse due to the continuous flow of the blood. Also, because of that, there's a loss of oxygen saturation readings, and the blood pressure cuff may not always be accurate. So you want to use a Doppler for blood pressure assessment. A goal map is usually 70 to 90 millimeters of mercury, and you want to monitor the VAD flow rates because the flow rate equals the patient's cardiac output. Many times there's a narrow or absent pulse pressure, and the battery life lasts about 8 to 12 hours per pair, so you always want the patient to take a backup monitor and batteries with them. And remember, treat the patient, monitor them for abnormal signs and symptoms, not treating the pump. ECMO is a life support machine that replaces the function of the heart and lungs or bypasses the heart and lungs. There's two different types, veno-venous, VV, and veno-arterial, or VA. VV is to support the lungs. It's for gas exchange only. VA supports both the heart and the lungs for gas exchange and hemodynamic support. The insertion site may be femoral or axillary, and there is research out there that mobility is occurring with both axillary and femoral cannulation, although I would say most often with axillary, less often with femoral. This does require an ECMO specialist to be with you at all times during mobility. An ECMO specialist may be a perfusionist or a registered nurse, depending on your facility. This device is life-threatening if dislodged. In summary, mechanical circulatory devices are most often encountered in the intensive care unit. Mobilizing patients with these devices requires special training. You want to ensure you're collaborating with the interdisciplinary team when mobilizing patients on MCDs, and they can be life-threatening if dislodged and require immediate attention.